Welcome to the Widowed Parent Podcast with your host, Jenny Lisk.
Hey everyone, it's Jenny Lisk, and this is episode 85 of the Widowed Parent Podcast. So I really had such a great discussion with Dr. BJ Miller for this episode. And BJ is a hospice and palliative care physician, and he has worked over many years now with patients who are seriously ill and patients who are dying. And I really thought a lot about what I wanted to ask him because he speaks internationally on this topic. He's a really well-known guy, and I really thought about what could I ask on your behalf while I had this chance to talk with him. And I started right out with my number one question for him. I asked him what he thinks that people who are dying have to teach those of us who are still alive. So listen for that. We also talk about all kinds of practical things. We talk about what is hospice, what is palliative care, how do they relate to each other, how are they different, what are the benefits of them, questions to ask, things like that. I really wish that I had some of this information and some of this knowledge, access to some of this while my husband was sick. And in fact, BJ's got he talks about this at the end, a group called Mental Health, where he actually is providing palliative care services and coaching basically to people virtually, regardless of location. And I wish I'd had someone like him to talk to back when I was going through this. So, like I said, we really had a terrific discussion. I'm going to put in the show notes BJ's TED Talk. I do think it's really a must watch. And please do share it with anybody that you think might be interested. Also link, of course, to his book, which is a really good mix of both practical and philosophical, I guess, for lack of a better word. So encourage you to check that out as well. Okay, I hope you enjoy my discussion with Dr. BJ Miller. The Widowed Parent Podcast is supported by Audible, and I'm excited to say that listeners can get a free audiobook and a 30-day free trial. Just go to audibletrial.com/widowedparent. That's audibletrial.com/widowedparent, and you get a free audiobook and a free 30-day trial of Audible. I hope you'll check it out. My guest today is Dr. BJ Miller. BJ is a hospice and palliative care physician who has practiced and taught in many different settings: home, hospital, clinic, residential care facility. And in his work, he draws upon his personal experiences with disability and his undergraduate studies in art history as much as his medical education. BJ speaks all over the country and internationally on the theme of living well in the face of illness and death. He's been profiled in the New York Times, interviewed by Oprah Winfrey, and is the co-author of the book, A Beginner's Guide to the End. His terrific TED Talk on the TED main stage, titled What Really Matters at the End of Life, has been viewed over 11 million times. And by the way, I'll put that in the show notes, because everybody should watch it. Most recently, he is the founder of Mental Health. And BJ is joining us today from Mill Valley, California. So BJ, welcome to the show.
Thank you, Jenny. It's nice to be here.
Yeah, well, I've really been looking forward to this conversation, and I've been thinking a lot about what I can ask you today that's really going to be meaningful for my listeners. I'm in this discussion, as always, I feel like I'm kind of standing in their place. I'm here with you, asking you questions on their behalf. Mm-hmm. And my listeners, by the way, are primarily widowed parents, so people who have lost a spouse and are still raising their kids or their teenagers. Mm-hmm. But I am hearing more and more from people who write to me and say, I'm a new listener. I'm not widowed yet, but my spouse has this terminal diagnosis. These are the ages of my kids. Here's kind of what's going on. And I'm listening to kind of get a sense for what might be, down the road for me here. So I want to kind of honor both of those groups. In our discussion today. And the thing I've really been thinking about, because I think, before we get to the practical stuff or what is hospice and all of these things, I think you're in a really unique position of working around death for so long, and I suppose many thousands of patients, people who are dying or gravely ill.
Mm-hmm.
But I've watched some of the interviews you've done, whether it was the one with Oprah or the one with Fei Wu on her live stream recently. The sense that I get is that you're so very much alive and so in tune with the human experience. And yet you work around death all the time, which is a topic that I think so many people try to run away from as fast as they can. So I guess my question is, what have you learned about death? Or maybe another way of saying that is, what do you think that the dying have to teach all of us who are still alive?
That's a beautiful question, Jenny, and a really important one, I think, for all of us to kind of think about. You made a comment there a moment ago about how that maybe I come off as being full of life, and yet I'm around death a lot. I think the main point to get across is what I've learned, and it's not just me. I mean, I think a lot of people who do this kind of work learn this pretty quickly, which is that it's not in spite of, I'm not full of life in despite being around death. It's more that I'm full of life because I'm around death, that they're related, that they have something to do with each other.
Okay.
And essentially, I think that's the mega point, which is that death is a part of life. Death, we talk about it, we language it, we conceptualize it as this thing which robs us of life. And in some narrow definition, that's true. Death is the thing that ends our individual lives. Okay. But if you pull back on the lens a little further beyond any one of ourselves, I mean, there's a lot more interesting going on. So this language, like the end of life, it's a funny phrase in part because it's the end of your life, the end of my life, but life will keep going, and that second half of the sentence is really, really important. So end of life care, end of life, that's the phrase we use. It's really end of any one person's life. Otherwise, life will keep going. And it's the interplay between the individual, the ego, and this world that we're all a part of that's so, so fruitful. So for me, I've come to feel that, the feeling of preciousness, like anything that really feels precious, I've come to see that what makes it precious is the fact that it ends. It has something to do with its finite nature. If we had unlimited time, Jenny, and, we could talk about whether that would be a good or bad thing, but let's just say we have unlimited time. Well, there would be nothing special about you and I taking an hour together to have this conversation. There would be, we'd just get to anything and everything. There would be no poignancy to the choices we make. There'd be no consequences to the choices we make. So anyway, when you start kind of looking at this subject of death a little bit more closely by virtue of being around it, you start to see how much of a foil it is for life, how much life is related to it, how much we gain from death in some important ways. And so I hope that makes some sense. It's sort of a conceptual framework. If our view, I think of myself as I go through life as an adult, I'm trying to create a frame for my life, a frame of reality, a way for me to understand reality that includes everything. Like the second I find my frame of reality excluding anyone or anything or any part of myself, I know that that's not a full take on reality. So there's this tension that I've found that I love, which is for me to keep pushing back on the reductive walls. I think we humans shrink our world to make it manageable. I think we need to remember that. We're the ones making our world small. Life is huge. Life is full of mystery. Life is all sorts of things. We try to make sense of it so that we can navigate it. At some point along the way and towards the end of life, I think it really pays to drop our frameworks and our concepts and our language and our constructs to acknowledge that reality is way bigger than any of us is able to manage to treat it at any 1 minute to the next. And death is the thing that keeps making me push back on the reductive forces and take a bigger view on life, that's more welcoming, that's more inclusive. And the nature, another way of looking at this is that death kind of reacquaints us with nature, the fact that we are natural creatures. I mean, I've grown up with this idea that it's humans versus nature, like life versus death. Again, those are just constructs. We are human nature is part of nature too. And I think the dying process is one big way to reacquaint yourself with that fact, with this bigger take on reality, where there's room for all your feelings, where there's room for every thought you've ever had, all that beautiful stuff. That's what I get. That's where I get chills. That's where I sort of get excited. And I feel like I've learned so much from folks who are closer to the end than I am. It's a long answer, but I hope that makes some sense.
Yeah, it does. And thank you for talking about that. And I think, my listeners are probably been around death more than most people, or had to think about death more than most people, because someone in their life has died or is maybe going to die. Well, of course, as I've heard you say, we are all going to die. We are all on the path towards death at some point. We just don't know what that point is.
Right.
But I guess I mean that my listeners are maybe seeing it more up close and personal than maybe most people, and certainly than they had would want to. Yeah.
And it's like so many things, like some of the things that have been most enriching in my life are things that I never would have chosen. But since they happen, and it forces me to see that there are forces bigger than myself, there's a proportionate, there's a right sizing that has for me, that puts my ego in check, but also reminds me that I'm part of something way bigger than my little old self.
Yeah. Well, let's talk about that, how you got into this line of work then, because I do think that is a important piece of your story of how you completely changed majors in college and switched your career trajectory. Can you tell us about how you got involved in this?
Yeah, well, I mean, it's just unavoidable that I had no interest in medicine before I was injured. So sophomore year of college, I was screwing around on a commuter train in New Jersey and had a metal watch on. And when I climbed up on top of the train, I got close enough to the power line that the electricity arced to my metal watch. And that was it. So that was my big near-death experience. I lost both legs below the knee and one arm below the elbow. And, it was very touch and go for a while, and then had to kind of reinvent myself once I was going to survive. I needed to re-enter the world and do something with whatever time I had. And so you can imagine, we could talk for hours about all I learned from that experience, but so much of that had to come to terms with part of my body dying, with me almost entirely dying, and watching how the world and how it changed my thinking, and how it changed the world, how it responded to me, et cetera, et cetera. So there's a lot of details in there, but suffice it to say that eventually that experience turned me on to medicine, both as this amazing thing that can help people like me survive, but also this very flawed thing that has a lot of problems and actually too often is the source of the pain itself. And so I was both drawn to the power, the poignancy of healthcare, of medicine, and also the failings of our system. It felt like a very rich place for me to work. It felt like a very rich place, or a welcome place, where my experiences as a patient would be relevant. And I think that was the big thing for me, was trying to find something to do with this big experience rather than to overcome it and put it behind me. That seemed impossible. So given that was part of my daily life, where could I exercise all that I was learning? And medicine lit up for me as a way to do that.
Yeah. Okay. And before you got turned on to medicine, though, you started doing art history. Like, can you tell us about how that has influenced your life?
Yeah. Well, yeah, right. So originally, when I was injured in sophomore year, I was going to major in Chinese language and East Asian studies. While I was in the bed, in the burn unit, I found myself thinking not much about Chinese language, and a lot more about what makes a human being, essentially. Like, what am I now? Am I less, in this very concrete way, am I less of a person now that I have fewer body parts, who am I now? Where's the place for me in the world? Can I will women ever want to date me again? Will I, all questions of identity. And that's where my mind was. And thanks to a good friend of mine, Justin, he would come visit me and we'd have long conversations, and our conversations would often turn to art. like, why do human beings make art? It's such an odd, wonderful, but odd thing that we have, this compulsion to take the raw material of our lives and create something from it. It's a really beautiful impulse. And it struck me that that's what I was trying to do with my life now. That I was trying to take these shards and put them back together in some way that meant something or felt good or something right. And I started to see that as a creative process. And so when I went back to college and rejoined my class that fall, I switched my major to art history so that I could really lean into this thing called art and why humans make it and what's behind it and how we pursue meaning as human beings. And that was so that study, there's a lot to say about that. I learned a lot about perspective and how to see the world. And it was that interest that then, so I graduated college and then realized I needed to make a living too. And I was parlaying the very same questions I was asking in the art world into the medical world. It was very much a continuum for me, studying art led me to medicine in a funny way.
It seems like a very unusual background for a doctor, and we would bring a different, but I think really important perspective then into your work now as a doctor, particularly given your work with hospice and palliative care patients.
You got it. And I was going to drop out of that. I went through my disillusionment. You can imagine a lot of people going to healthcare or medicine they bring a lot of idealism to this mix. The service, they're going to, serve people, be there for people, help people, do all sorts of beautiful things. But then the practice of medicine can be pretty brutal and can kind of beat it out of you. So there's a lot to say about that too. But I'll just say, deep into my medical training, late into medical school, my sister had died. I just was in a disillusioned place around what it meant to practice medicine. I was going to dump it all together. But then I got turned on to palliative care, and that reawakened my interest in all of this. And it was very specific to palliative care. It was, and so maybe it's a good moment to mention what the heck palliative care is.
But yes, please. That's because we're throwing these terms around: hospice, palliative care. A lot of people use them in the same sentence. So can you tell us? Yeah,
it's really important that we all understand this. So palliative care is simply the interdisciplinary pursuit of quality of life. Or, if that sounds too hokey, you can simply say palliative care is the treatment of suffering. And the important distinction there is the rest of medicine is the treatment of disease. We're treating suffering. Suffering is a multi-layered human subjective experience, whereas the rest of healthcare is hell-bent on objectifying you. Palliative care is in this total embrace of whoever the hell you are, Jenny, whatever your idiosyncrasies, your likes, your dislikes, all the subjective stuff that goes into how you experience illness, how you experience life. That's our subject matter in palliative care. So it has nothing to do with death. The thing is, it got tricky, is palliative care grew out of hospice work. Okay. So in the 1970s and 80s, hospice grew up in the U.S., and one of the realizations was, why do we wait to the final weeks and months of life to surround people with love, to communicate openly, to lean into their symptoms and care about their pain and how they're feeling, to care about the family? These are all tenets of hospice. But we all realize, well, why do we wait till we're dying to provide this kind of service? Why wouldn't it be much better if we started doing this earlier in the mix? So palliative care grew up in the 90s and the 2000s to get beyond the end of life as the theme. So palliative care has, a lot of my patients I've been seeing for 12, 13 years, and some of them are in remission. They're not even planning on dying anytime soon, but they're still relevant to palliative care because they're suffering or because they're pursuing quality of life. They're not yet relevant to hospice because they don't have 6 months or less to live. So cutting through all that, hospice is a kind of palliative care that is reserved for the end of life, the final months of life. But palliative care otherwise is not invested in your death in any way. You could be dying 100 years from now and you'd still be relevant to us in palliative care.
Okay. That does make sense. Yeah. So it's almost like, if now listeners can't see, I'm drawing circles in the air, but the big circle is palliative care, and then hospice is a subset, particularly reserved for that end of life, whatever that short time period is.
You got it. Exactly. But the training, so, for the workforce, The field is now called hospice and palliative medicine. So it is one field. So the training is whether I'm working with a patient who's dying in a week or working with someone who's not planning on dying anytime soon, it's much the same. And the theme that lit up so much for me that reawakened my interest in medicine was very much this piece of palliative care, which is, I care about you, Jenny, whether or not you're fixable, whether or not you're curable. Healthcare, medicine in general, is really great. If it has a cure to offer you, a treatment to offer you, great. That's when medicine really shines. Medicine falls on its face when the proverbial, we have nothing more, there's nothing more we can do. That sort of abandonment moment, just because you're not fixable anymore, doesn't mean you don't have more life in you, doesn't mean you're not worth caring for. And this is the space that palliative care comes into. So for me, there's something infinitely more interesting and important for me to dealing with things that I can't fix. And you can see how, for me as a disabled person, that was really powerful. I'm not fixable. I don't want people to look at me as something that needs to be fixed. I do want someone to look at me and bear witness and see me and feel what I'm going through and empathize with me. So this is where I fell in love with medicine again, was this idea that I could be with people and love them irrespective of whether they're fixable. That's a really key distinction.
Yeah. And it's reminding me of something that I don't know if it was in one of your interviews or articles. You said something about, until the moment you're dead, you're alive.
Yeah. Dying people are alive too. I think we need to remember that. Yeah. Yeah. Good. Okay. Well, thank you for going through that. So in terms of palliative care, then, it sounds like, because I know with hospice, generally you have to decide to stop, chemo or stop treatments or stop things that are in the fixing objective. But palliative care, it sounds like, does not have that element and could be in conjunction with fixing efforts. You got it. So this is where it gets so dang confusing. I feel for the public as we try to parse these things out. So you just said it was right on, Jenny. The thing to appreciate here, even if it's the same philosophical kind of pursuit of care, the same approach to care, what the difference here is in 1982, hospice, Medicare defined the hospice benefit. It became an insurance benefit. So now when we say someone is on hospice, we really mean they're on the hospice benefit, the insurance bundle that goes around this type of care. And that insurance designation requires that two doctors say you have 6 months or less to live, which is always just a guess. And that also requires that you forego any other attempts to cure the illness. That either you don't want any more of those attempts, or there is nothing more to try. But either way, to go on to hospice conventionally, there are some efforts to revisit this policy, but to go on to hospice in the conventional sense means you got only a few months to live, and you're no longer trying to cure that illness.
Gotcha.
And that's a really tough crossroads. Because the truth is, first of all, we're terrible at prognostication. There's nothing that you don't change color when you have 6 months or less to live. There's no, and secondly, there are certain treatments that might help you live a little bit longer, might not cure you, but might help you live a little bit longer. Or maybe there's a new treatment coming down the pike that might cure you and you would want to try it. Of course, those make a lot of sense, but if you're on hospice, you would not have that access to those things. So palliative care grew up around the hospice benefit to free itself from these restrictions. So ideally, palliative care works best right alongside intensive curative care efforts too.
Okay, and so if somebody is being treated, or they're the caregiver, their spouse is being treated, and nobody's said the words palliative care to them, can they ask, or how do they access this? Yes.
So one of the problems is that, there's a lot to say. I mean, palliative care is still developing. We still have a dramatic shortage of people trained in this kind of care to meet the need. So that's one point. But better answer to your question, Jenny, is doctors suck at communicating. Doctors are really bad at finding some way to tell you that death is coming. Doctors are really bad at acknowledging quality of life issues. So I'd love to say that I'd love to guarantee you and your listeners that your doctor will tell you when it's time for palliative care or when palliative care would be helpful. But I can't promise you that. Most of the time, that's not. Most of the time, if doctors think to refer to palliative care, it's way, way too late, because everyone keeps conflating palliative care with end-of-life care. And so everyone's like, oh, I don't want palliative care because that means I'm dying. And so there's all this avoidance. That's why it's so important that we realize that palliative care has nothing to do with dying. So I would encourage you and your listeners, this is where navigating healthcare these days really requires you become an advocate. So don't wait for your doctor to offer you palliative care. If you are suffering in any way more than you think you need to, whether it's symptoms or crappy communication or the family's falling apart or you're in grief or you're just struggling in ways you can't even name, ask for palliative care. You be the one. Don't wait for your doctor to offer it to you.
It's interesting, because normally as a layperson, I would think, okay, another doctor, whatever their specialty is going to do more medical stuff. They're going to do something with medicines or surgeries or treatments or diagnostics or something medical. And do I really need one more medical person? Yeah. Right. But I think I'm hearing you saying there's so many more pieces about the person's life, about their relationships, about their. Can you talk to us about get some examples? What do you mean by what can palliative care do?
Yeah, no, it's a really good point. So yes, we still rely on the doctor, the MD thing a lot, because that's how healthcare is wired in this sort of hierarchical way. But palliative care, like hospice, by definition, for a program to say it as a palliative care program, you have to have a doctor, a nurse, social worker, and chaplain at the very least. Okay. And also volunteers, art therapists, anything you can imagine. When quality of life is your goal, well, there's all sorts of things that enter the picture besides medications. So one thing to get clear, when I say invite palliative care into the mix, I'm not saying just yet one more doctor. I'm saying invite this holistic view on care. Invite the chaplain in to talk about spirituality. Invite the social worker in to help debrief and process your feelings, your emotions, also to get a sense of logistically what's possible in the community, or the nurse that can help be there and to explain to you all that's going on, the doctor to prescribe medications. All of that comes together. So that's one big point. And yes, for examples, Jenny, so like a lot of people come to me, originally, oftentimes there's like a symptom management moment. They'll seek out palliative care because their pain's unmanaged, or because they've got this nausea with chemo or whatever that the oncologist just can't get on top of. So very often they'll come to me with this very sort of dry, tactical question. But usually within a visit or two, we end up talking not so much about their pain or pain medications, but about where in their daily life are they doing okay? Where do they feel right in the world? Are they sitting on a lot of unspoken wishes or desires or concerns that there's just no place for them? And now that their role in illness is changing within their family, how are they feeling about that? How is their identity shifting around being a sick person now? These are the questions that are much more interesting, much meatier, but usually we have to have a way in, and oftentimes the way in is, I've got pain, doc, can you help me with my pain? But where we end up going is to these places of identity, of meaning, spirituality, revisiting how they want to be with what time they have left, revisiting their dynamics with their family, maybe coming to terms with a long-lost friend or family member that they knew that they wanted to reconcile with. That's the kind of stuff we end up doing a lot of work on, not so much on the pain medication per se. That's just a Trojan horse. Yeah. Okay. Well, and so this is making me think, are there some questions, as a hospice doctor or a palliative care doctor, questions that those doctors wish their patients would ask, things maybe they're afraid to bring up, or things that, I don't know. Can you talk about that a little bit? Yeah. I mean, so one of the data suggests that why doctors are pretty crappy at navigating a lot of these questions is because we have this idea that if we talk about death or talk about loss even, or talk about all of the things that are, leaving a life, that we are going to, quote unquote, dash hopes. And so doctors end up propping up these sort of false realities because they don't want to decimate your hope. And people are coming to us doctors for hope. That's sort of the conventional, what data suggests is the hang up. So you as a patient, as a family member, one of the ways to kind of get past the doctor's discomfort is doctor's not going to know when it's safe to bring up death without crushing your spirit. So if you're wondering this, you can say, hey doc, if you're wondering about time left, you push them to say. They may not offer that to you, but if you really want to know your prognosis, if you really want to know what this treatment or that treatment is going to look like, my favorite question that rarely gets asked is, hey doc, what if I don't do this treatment? It's always shocking to me how many family members and patients say yes to treatments because they don't want to hurt their doctor's feelings, because they care about their doctor, but they end up protecting the doctor's feelings. So they oftentimes say yes or don't ask questions about things and want to convey trust. And they'll just happily go down these paths with doctors, whereas the doctor's sitting there waiting for the patient to tell me what they're willing to live with and what not, whether to proceed, whether to take a different path. So if that makes some sense. I wish my patients asked me, hey, what happens if I don't take this treatment? Hey, how much time do I have left? And maybe maybe I want to spend more time out of the clinic and on the beach or whatever it is. I love when patients start taking the reins and realize this is their life and that I'm here to help them versus them trying to please me. I think a great question to ask people is, especially if you know that the end is coming at some point and you know, for example, that you'd want to die at home or that comfort's a priority to you. A great thing to ask your doctor is, hey doc, when do you think hospice is right for me? Very often you'll get a doc say, whoa, I don't know. They'll make them uncomfortable when it's your life. So you be the one to drive those questions.
Yeah.
You'll get to a better place.
Yeah. Okay. All right. Thank you. And, this is reminding me a little bit about in the book, which I'm going to put a link in the show notes for sure, because I think that everybody should take a look at it. You have a whole chapter. It's called Love, Sex, and Relationships, which I didn't necessarily expect to see in a book called The Beginner's Guide to the End. Now I'm looking here on the side of my desk, and you've got like how to I don't know, give a eulogy and what you need to know about paperwork and advance directives, and you've got a lot of practical things and you got some philosophical things, and then you've got a chapter called Love, Sex, and Relationships. It sounds like this is getting in like maybe a topic you can broach with a palliative care or hospice or maybe any doctor. Yes. So great segue, great example, Jenny. So feeding off that last question, anytime a patient either is conveying a personal preference to me or asking me something about vulnerability or intimacy, I get thrilled because I know that they're not dying before they die. And I think in a lot of ways, we start closing the doors before they need to be closed on sex, on humor, on all sorts of things that feel like this is too sacred. People get lots of weird sort of feelings around this stuff and accidentally start shutting off parts of their lives before they have to. And sex is a huge one. Obviously, and I don't just mean intercourse, I mean sexual touch and sensuousness and contact, that sort of physical intimacy. That is primal stuff. That's right up there with air and water and nutrition. It doesn't have to be any one way. It's not an intercourse thing, but touch. This is primal stuff. And so this is where the medical system, we should do a much better job of asking you about that and making a safe place for you to talk about that. But that's not the norm. So I would love it if more patients would own their sexuality, their sensuality, own their body while they still have it. And yes, ask me about whether it's safe to have sex. Ask me, share with me their concerns so that we can talk it out. Sex may need to shift, but it doesn't need to go away. So these are kinds of conversations that may be hard for me to broach because of my own discomfort as a doctor in the room or not knowing what's right for you, but you can cut through that and bring it up to me. I think sexual intimacy is one of the biggest, and I've noticed the times where it's come up with patients have been huge bonding moments. I've had many patients when I've just touched their arm and they start crying just because no one's touched them, no one's dared to think of them as sexual beings anymore, and just by touching or even asking, there's a therapeutic moment. Well, and I think people are worried, is the person going to break, or is it going to harm somebody, or like, is this even okay, or is it okay to talk about, but it sounds like in the context of this, a really good palliative care doctor, it's one of these, I think in the beginning you defined it as like the total lifestyle of the person, or I forget your words exactly, but it's not just the medical piece, it's every element of a human being's life.
Yes, that's right. It all goes into whatever composes a human being. This is this huge distinction between centering care on a human being versus centering care on a disease. Sexuality is probably not really relevant to the disease process of most cancers, for example. So if you take this narrow view of healthcare as this sort of disease focus, well, then this stuff doesn't have a place. And and a lot of your listeners probably have felt that in the healthcare system. There's no space or time for many of the parts that comprise us, the emotional world, the spiritual world, the sexual world, etc. So yes, these are the kinds of things that palliative care generally is very good at focusing on. And I should say palliative care team, like we were talking earlier, not just the doctor. You might very well get a lot farther talking about sexuality with the chaplain or the nurse than you would with the doctor. Yeah. But explicitly, this kind of stuff is on the clipboard of any palliative care team, where it's not likely going to be on the clipboard of your oncologist or your cardiologist.
Gotcha. Okay. Yet another reason to think about engaging them early and not waiting. In fact, I think one of the things you mentioned in your book is many people think they need to wait until like the very last possible second to say, okay, fine, I'll let hospice in, or okay, fine, I'll let palliative care in. Yes. It sounds like you're advocating kind of the opposite approach.
Totally. Absolutely, I am. To be unequivocally, absolutely. The vast majority of people who I've ever cared for is, in hospice and palliative care, the refrain, again, it's not just me, this is the field. The refrain is, wow, why did I wait so long? Why? We're just sitting around suffering needlessly too much of the time. I mean, there's plenty of suffering that's just going to be what it is. And that's where we accompany each other and we don't run away from each other. But there is some suffering that has an answer. And then there's something that can be done about it. And we wait way too long. We suffer needlessly way too long as a rule. Worst case scenario is if you involve hospice or palliative care early is you realize, well, maybe you don't really need them just yet. But you've met the team. They're there for you when you are ready. Absolutely. As soon as you think to call, make that call.
Okay. All right. Thank you. And so I'm thinking about now, for listeners who may be not quite widowed parents, who maybe have a terminally ill spouse, or maybe other listeners who are just, thinking about supporting an elderly parent or other people in their lives. Let's say someone says, okay, it's time to bring the hospice team in. What does that look like? What are the options? Is somebody at home? Are they in a hospital? Are they in a place? Like, how does this work?
Great. So hospice, the bulk of hospice care in this country is meted out in the person's home, or wherever they call home. And some hospice programs see people in their vans, see people in nursing homes, see people wherever they call home. So the vast majority of hospice care is wired to come to you, which is generally wonderful. Most of us say we want to be at home when we die. Most of us would prefer to be at home than in the hospital, et cetera. So in general, this is a wonderful service. And by far the way to get the most services, the most support into your home is through hospice, bar none. End of story. Have it covered. So what does that look like? A day on hospice? So let's just say you enrolled in hospice tomorrow. Usually they're pretty good at meeting you that day. The nurse will often come out to the home, meet with you, tell you about the things they can and can't do, etc. And pretty quickly you're off to the races with them. Because they know time is of the essence. So you'll meet your team pretty quickly. Eventually you meet a chaplain, social worker, nurse, and doctor in some format. And so what it looks like is usually they'll send a home health aide out, maybe an hour or two a day to help with bathing and stuff around the house. And then maybe a nurse will come out 3 times a week to check on your medications and make sure you're as comfortable as can be. And then otherwise a social worker or chaplain, they're kind of more on call. They'll come in as needed if an issue arises. But it's pretty fluid. And if you're doing well and you've got everything you need, it's not like the hospice guys linger in your home. In fact, the big problem with home hospice is with that aide there 1 hour or two a day, and then maybe a nurse a few times a week, there's still 23 plus hours of any one day that there's no one there with you as a family at home. And so one thing, hospice is an amazing addition, but they're not going to do everything. So there's still a lot of work for family members, even when hospice is involved. So very often patients will want to augment, get more home health aides, and sometimes will pay out of pocket for a few hours a day of a home health aide to be there. Or if, sleeping's an issue, sometimes overnight to have a home health aide if the patient might want to get out of bed and it's a fall risk, etc. So you can augment that support either with volunteers, with family members, friends, or you can hire aides to supplement. But anyway, that's sort of the way the daily life of being at home with hospice plays out. One other thing to mention in that is hospice is covered in facilities too. There's a lot of sort of policy wonkiness around this. But I guess the point I want to make here is a lot of us say we want to die at home, but for cultural reasons or personal reasons, very often dying at home just isn't possible, or being comfortable at home isn't possible. Maybe family members burn out. It maybe just gets to be too much. And so what I'd like to see more of, they exist, but increasingly I'd like to see more inpatient, like residential hospice facilities, these sort of homes away from home that aren't nursing homes, that aren't hospitals, that people can go and live until they die. And those places exist. And there are inpatient hospice facilities. They're just few and far between. But it's really worth asking about what's available in your community. Because like I say, even if you want to die at home, sometimes it gets just too much.
Well, I was wondering about that because my husband was on hospice at home for 3 or 4 months maybe. Mm-hmm. And maybe a month or two in, I was like, I can't do this anymore. Mm-hmm. Right? Like it was so physically taxing.
Yep.
Right. And I put in some calls, and I'm like, because you just, as a layperson, you think, oh, there must be a place, right? Like there must be a hospice place he can go to. And I honestly can't remember why the answer was no, but the answer was no, you're out of luck. Like keep going. Yeah. And so I guess, for anybody who may be in that position, what questions should they ask, or who do they call, or how do they figure out if there's a place someone can go, or what their options might be?
Yeah, well, ask any hospice team should know, generally speaking, will know what resources are available in that community. Okay. So ask early on, even if you don't plan on using it, just to get a lay of the land, excuse me. Hey, in my town, do you know if we have an inpatient hospice facility, or do we have any residential care facilities that take hospice patients? Most communities, and sadly the answer is no. These places are very hard to fund. There's a lot to say about that. These places are still too rare. There are places that have, quote, an inpatient hospice facility, but to qualify to be in there, you might have to meet certain levels of need. And this is where it gets really kind of confusing, and it's case by case. So maybe what happened with you and Dennis, Jenny, there may have been an inpatient hospice facility, but maybe Dennis's needs didn't meet the entry criteria for that place. I'm guessing, but that's possible. Mm-hmm. So that's one answer to your question. The other thing is it's too little used. One of the benefits of the hospice benefit, one of the things that you get, is what we call respite care. And this is for families. So this is not so much for the patient per se, it's really for the family. So just like you described, Jenny, if it's getting too much, it's a lot of work, and it's just taxing and physically, emotionally, in every way. And if you, family member, if you, Jenny, need a break, the benefit will pay for Dennis to go to either to a hospital or nursing home for 5 days while you go take a break, go whatever it is. So
sleep.
The rest, yes,
stop administering thousands of pills a day. Stop giving shots for 5 days.
Exactly. Just stare at a wall for a change. Yeah. Whatever you need to do. But that respite benefit, that's what it's called, the respite benefit. It's too rarely used. It's there for you for exactly this reason. So I would push any of you guys to make sure to ask about it.
Okay, good. Thank you for bringing that up. I learned about that from reading your book. I wish I'd known about it. And, maybe somebody told me about it and it went over my head. I don't know. But anyway, and I don't know that we're going to have time to talk too much about your book today because we are running short on time. But I do want to ask you about mental health, because you're now providing some services that I think might be very helpful to some of my listeners. Can you tell us, what is Mental Health? What are you doing?
So Mental Health, METTLE, metal, like your inner reserve, like find your metal. So Mental Health is, like I said earlier, palliative care is not, we don't have enough palliative care programs in this country just yet. And it's regional. Like the Southeast, for example, is woefully inadequately addressed by palliative care. Parts of the West, there's geography issues around this. But now that thanks, we're all getting a little bit more used to online work. So Mental Health is a place online where anyone can come get palliative care. So you don't need a doctor's referral. You don't need to be in a geographical location. Just give us a call. So Mental Health is meant to make palliative care more accessible. So that's what we do. We are that extra layer of support. So if you're burning out or grief is an issue, or you're wondering how to navigate hospice, or your questions about treatment decision-making, all that kind of stuff, you want to talk about sexuality, you want to just vent, you want to howl at the moon, we're something of like a hotline that way. You can call us anytime to get that kind of care.
Well, and I was interested to hear, as I know you serve patients, caregivers, but I think I heard you mention somewhere that many or maybe most of the people you're actually working with right now are the caregivers.
Yeah, I think that's true. We haven't added it all up, but my guess is that most of our clients are actually family members, caregivers.
Yeah. What do you think are some of their main concerns? What are you helping them with?
Well, very often it's them. Very often the model is sometimes they're doing such a good job of caregiving that the patient is doing just fine, but the caregivers are operating on fumes. They're foregoing showers, eating, napping, exercise, all that thing, because caring for someone who's very sick is just all consuming. So a lot of the work we do with the caregivers has to do with their own self-care and processing their own emotional load. Because very often it's the case too. I mean, we have hospitals erected to patients. We have systems and structures for patients. Socially, we know to ask about how the sick person's doing, but very rarely does that care extend to the caregivers. And in this country, we have something like 50 million family caregivers who are trying to hold down a job and do other things while caring for someone at home. 45 million people.
Wow.
And that's an invisible workforce who are suffering without resources, don't feel necessarily safe bitching about their own issues because it's the patient that's supposed to get all the attention. Whatever it is, all the ways caregivers talk themselves out of needing anything for themselves.
Yeah.
We help them revisit their own care, their own emotional load, etc. So that's a big piece of what we talk to caregivers about. Also, we end up doing a lot of sort of reassurance. So it's almost like a second opinion. Like, hey, I'm interested in X, Y, or Z treatment, or I'm actually thinking about maybe saying no to this treatment. What do you think? Or my doctor, my oncologist, I can't find a way to talk to them in a way that I feel heard. Sometimes I'll coach a lot of our clients through communication with their medical team. So reassurance, second opinions, communication tips, emotional processing, grieving. This is where a lot of the work with the caregivers are. Anticipatory
grief, presumably.
You got it. Anticipatory grief. Thank you for using that phrase. It's a big deal. We grieve things even before the loss happens. It's really important to understand that.
I had never heard that word before I got involved in this whole grief world, but it's a real thing and important, I think, for people to understand. Yeah, good. Gosh, we could just keep talking about this all day. This is there's lots of stuff, and I've been going on, but yeah. No, it's great. It's wonderful. And I think it's a really important topic because, like I said, most people don't want to talk about it. They don't want to talk about death. They don't want to talk about dying. They don't want to talk about illness. Yep. It's uncomfortable. It's scary. Most of my listeners are, though, dealing with it in one way or another, or have been dealing with it over the past few years.
And I'd say, as uncomfortable as it is to talk about it, I think the basic math is it's ultimately even more uncomfortable not to talk about it. And the way we kick the can down the road, I've worked with so many families who waited too long to ask this or that question or come to hospice or palliative care, or whatever it is, and then we're filled with a lot of regrets because they didn't turn their attention to the fact that their life was finite, that their time was finite. And then all of a sudden the clock's running out. And if they had let themselves think about their mortality, they may have made some different decisions along the way. They have had fewer regrets. And I think a lot of the work of palliative care in some ways is avoiding regret more than seeking solace. A lot of it is avoiding more pain. So anyway, I just want to pick up on that idea. Yeah, a lot of us don't know how to talk about this subject. It's scary. But for my money, it's not as scary as not talking about it ultimately.
Yeah. Well, I was going to ask you to wrap up, but maybe you've just covered it. Tell me if you have, that if you could just say one final thing to us of what we should know about death and dying. What do you want to leave us with?
Well, I think we started with this idea that death and dying is a part of life, not its antithesis, and that can soften our gaze on death, and it can make it this less scary foreign invader thing and more natural and a piece of us, an essential piece of us. So we started the conversation with that, and that to me is the biggest. But I think related to it, maybe I'll just end on the idea that closure. I find it useful to remind myself and others that closure, this idea of closure, is something that I think I hear a lot of us seeking, is an invention. That's a made-up thing. Just like the idea that grieving should only last a couple months or something like that. The truth is, it's much more complicated than that. We grieve forever. Closure is something we create. You can weave together a nice narrative. You can find closure. You can make closure. But I find that useful to say that because sometimes people don't feel closure and they wonder if they've done something wrong. My point is, no, you haven't done anything wrong. You're just feeling the reality that closure is something we make up.
Well, terrific. I think that's a great place to end. So my guest today is Dr. B.J. Miller, who's a hospice and palliative care physician, the founder of Mental Health, and the co-author of A Beginner's Guide to the End. So, B.J., where can listeners find you and find your book and find Mental Health?
Well, thank you, Jenny. Come visit us. Mental Health is just mentalhealth.com, METTLE health.com. We're on Twitter at metal_health. And there's also at BJ Miller MD for Twitter. And then for the book, we have a little website that's the acronym for A Beginner's Guide to the End. So abgtte.com. You can visit us there too.
Terrific. All right. Well, BJ, thank you so much for speaking with me today.
Thank you, Jenny. I appreciate your questions so much. It's good to talk to you.
I hope you enjoyed my interview with Dr. B.J. Miller as much as I did. You can find show notes and all the links at widowedparentpodcast.com. Look for episode 85. And a shout out today to all of my new listeners, wherever you may be. I'm sorry that you need to be here, and I'm very glad that you did find the podcast, and I hope you're finding it useful and interesting. I saw this week that I appear to have a new listener in Turkey, so welcome. I'm very glad you're here. And also I've heard from a number of other new listeners in various places in the world. So thank you for writing to me and letting me know what you have found helpful and even suggesting a topic or asking a question of something that I may be able to cover in upcoming episodes. And hey, if you have a moment, do pop over to Apple Podcasts and leave a quick rating and review for the show. It really helps other widowed parents actually find the show if it has more ratings in Apple Podcasts. So thank you in advance for taking a moment to do that. Okay, that's all for this week. And as always, thank you for listening. And until next week, keep smiling.
Thank you for listening to the Widowed Parent Podcast with your host, Jenny Lisk. Connect with us on social media and at widowedparentpodcast.com.